Hi, good afternoon, everyone. Thanks for making it in person to the Grand Round. And so we have our esteemed speaker today, Dr. Dheeraj Gandhi. He is the professor of radiology, professor of neurology and neurosurgery, vice chair for academic affairs at the University of Maryland Medical System. He's going to be talking to, he has many grants, and including the most recent one on robotic microcatheter development. And so he is very, very active in research and development of new technologies, and has done exceptional work in developing focused ultrasounds, MR-guided focused ultrasound. He's going to be talking to us about that. And I think this is a modality of the future, and it is going to have great neurologic and non-neurologic indications. And I think we should be a part of that. And that's why I think we are looking forward to his talk to see how we can use this technology to our best advantage going forwards. On this note, Dr. Gandhi.
Thank you, Amit, for this very kind introduction. And also, I really appreciate your invitation to come and speak to you guys today. Also, really enjoyed visiting this beautiful institution and your department. I'd never been here before, so thank you so much. Also, got to meet some old friends that I hadn't seen in a while. And now I get to talk to you about MR-guided focused ultrasound, which is truly something that is near and dear to my heart. I believe that within the next few years, this technology is going to become so mainstream that this will define how minimally invasive neurosurgery and neurointervention is performed in the future. Now, looking back at my career, I feel that I've had two gifts or blessings. Number one, when I got introduced to the field of interventional neuroradiology back in 2003 and decided to pursue that as a career. And then second time, serendipitously, when our chair in 2013 came from University of Pennsylvania, Dr. Elias Mellum. And as a part of his chair package, he decided that he will allot certain funds to buy MR-guided focused ultrasound system. So we were rather ahead of the curve in terms of adopting this technology. So we've been witness to a lot of trials, got to participate and also learn from the early days. Looking at the two things that I do, endovascular and minimally invasive MR-guided focused ultrasound, I feel that even though they are very different from each other, they also have a lot in parallel and common, because these are both evolving technologies, image-guided, and the speed with which they have developed and got incorporated into the clinical practice is just breathtaking and overwhelming. These are some of my disclosures. The ones that might be relevant to this talk are bolded. Focus Ultrasound Foundation has been very kind to me. They funded 3 of our ongoing trials. University of Maryland funds another grant that is helping develop a prototype for pinless focus ultrasound. And Insight Tech, of course, provides a lot of logistic support to our MR-guided focus ultrasound program. And they have been visionary in investing in pivotal trials that I would allude to in my talk today. Now, back in 2003 and 2004, now thinking about my first blessing, interventional neuroradiology, if we came across this kind of a mammoth right posterior cerebral artery fusiform aneurysm, we would have little, if anything, to offer to this patient, other than perhaps put a lot of coils and eventually end up occluding this blood vessel. Little I could imagine even that just a couple decades later, we might be able to completely refashion a new vessel out of this fusiform aneurysm without even putting a single coil, and that too within a matter of perhaps half an hour, 45 minutes. This case was done with a single pipeline stent across posterior cerebral artery. And then all of us have been witness to this dramatic growth of large vessel occlusion thrombectomy. This is fueled by technical innovation and also high quality randomized controlled data that has assured that this technology is here to stay, and not only here to stay, this is so mainstream that it is focal point of stroke therapies today. Also, in terms of its effectiveness, it can even be compared. Now, people compare this to defibrillation for cardiac arrest victims. Look at this case, a 6 French catheter traversing from cervical carotid artery by itself within a matter of seconds into the precavernous segment. And then when it comes to precavernous segment, it can then be pushed without microcatheter or microwire within a matter of 4 or 5 seconds into the middle cerebral artery, very atraumatically. And once it gets there, it was hooked up to suction, and out comes a piece of calcified aortic bicuspid valve that had embolized to middle cerebral artery. This patient was actually a colleague of mine, a nursing colleague who was found down in bathroom, luckily came to us very quickly, and he went home without spending a single hour in rehabilitation. Something like this would be unfathomable a few years ago. Because of these technologies and innovations, acute cerebrovascular disease has seen a sea change. Mortality statistics of New Haven County, I was looking at it, went down from 14 per 100,000 for ischemic stroke patients in 2000 to 8.3 per 100,000 just in a span of 19 years. That's a huge progress. Now, what has happened to acute cerebrovascular disease, unfortunately, is quite the contrary or opposite of what's happening with chronic neurologic illnesses. In fact, with the rapidity with which the prevalence of chronic neurologic diseases is rising, it is going to overwhelm even the most sophisticated healthcare systems by mid-century, including United States. Look at some numbers. Alzheimer's disease diagnosis is made in the United States every 66 seconds. And the number of AD cases will triple by 2050 because of aging population. Now, if all of us here in this room were fortunate enough to become seniors one day or live up to be seniors, 1 out of every 3 of us will die from Alzheimer's disease or related dementias. And what about Parkinson's disease? A new diagnosis of Parkinson's is made every 9 minutes in the United States. The medical breakthrough, levodopa, was made in 1967, and it is still considered to be standard of care medical therapy for initial treatment of Parkinson's disease. That's the year when Lyndon Johnson was president and minimum federal wage was $1.40. Just think about that. If you look at combined economical impact of 4 common neurological disorders, Alzheimer's disease, tremors, Parkinson's, and neuropathic pain, this costs our society an equivalent of $1 trillion. So you might think about, there's a lot of discussions about debt ceiling. So I think about how much does that cost? $1 trillion is equivalent of spending $1 million per day for a consecutive period of 3,000 years. This is not tenable, of course. This has to change. We need disease-modifying therapies desperately for these chronic neurologic disorders. Now, it's not that we don't have access to some of these disease-modifying agents. We have radiofrequency ablation and we have deep brain stimulation that are available at least for Parkinson's disease and tremor patients. The problem is that these are brain-penetrating technologies. Even in the very best of hands, there is 2% risk of hemorrhage and strokes. Moreover, when it comes to deep brain stimulation, there's lifetime of battery changes and not an insignificant risk of hardware failure over long term. So few, if any, patients find these therapies acceptable for use, especially for disorders such as essential tremors. What if we have a technique that requires no cranial incision or burr hole. It can be done with real-time feedback control, meaning a physician can go in, examine the patient, and stop the therapy when desired therapeutic effect has been obtained. Leaves no neurosurgical footprint, either within the scalp, the skull, or the brain. Could be done awake without even needing sedation most of the times. Has excellent safety profile with very little risk of off-target injury. And what if you could send the patient home after 2 hours of therapy? At this early stage, MR-guided focus ultrasound checks all of these boxes already. The only invasive part of MR-guided focus ultrasound today for thermal ablations is that you have to shave the patient's head, you have to give lidocaine, and you have to put this frame, which can be a little bit painful. This is a CRW frame that is put in so that the head is affixed in position. And once that is done, the patient's head is coupled to MR-guided focus ultrasound system. This is a hemispheric array of 1,024 elements. And then chilled degassed water is circulated around patient's scalp to keep it cool. The patient is then shuttled to MR. A preoperative imaging study is fused to the intraoperative imaging study. Low-frequency sonications are performed, focusing onto the target area of the brain, raising the temperature to somewhere in the range of 46 to 47 degrees. If the patient is progressing in appropriate therapeutic direction without any side effects, then we elevate the temperature up to 55 to 57 degrees. At 55 to 57 degrees, there's almost a guarantee of a therapeutic ablation occurring. And then the frame is removed, patient examined, and after a couple hours, they can be sent back home. The fact that ultrasound beams can generate heat has been known for a long time, since 1927. In fact, as early as 1950s, Fry brothers designed this 4-element transducer system working at Washington National Naval Laboratory. They could couple this 4 ultrasonic system to a craniotomy window to the brain directly. And they demonstrated back in 1950s that they could create a well-demarcated deep-seated lesion within monkey striatum. Even with a 4 transducer system, you can see the well-demarcated margin of this lesion without any intervening injury to the brain parenchyma. Now, there was a lot of excitement in this technology, but it never caught steam because, number one, you still had to do craniotomy to do this. Number two, in 1967, a wonder drug was introduced, levodopa, that moved entire field away from lesional surgery. Now, the biggest masterstroke in this field came in 2002 when Clement and Heinonen, working at Brigham and Women, came up with an innovative solution of hemispheric array transducer. Each element of this transducer could now be driven, so-called the phase driving algorithm, in terms of its phase as well as amplitude. They used a priori CT data to calculate incident angle of the beam, the thickness and skull density, and incorporated this into the phase driving algorithm. Now, if you just fire this hemispheric transducer by itself, this is what happens. The pressure waves are all over the place because of refraction, reflection, beam attenuation that can occur. On the other hand, if you apply this phase algorithm, this is in cadaveric head, you can focus these beams into a laser beam focus within a sub-millimeter precision. So this now opens in a door for in vivo application of this technology in human head. The first disorder to majorly benefit from this technology has been essential tremors. More than 5 million people in the United States are affected alone. We probably all know somebody in our family or in friend circle that probably has this disorder. As the population is aging, this is going to continue to increase at an alarming pace. Now, the problem is that a lot of things that you and I take for granted are not so easy for patients with essential tremor: eating, grooming, cooking, driving, using a phone, computer, or even writing. As the disorder progresses, these things become so difficult that many of the seniors are confined to their homes. They are embarrassed to go out in public. This can be highlighted through this beautiful video that Focus Ultrasound captured of one of our patients, Rick Trader, who was generous enough to do this for FUS Foundation. He was treated in essential tremor trial at our institution. He had never known life without tremors. He had always had tremors since his childhood. But as he aged, things became very difficult for him. I'll play this video. On the day of the treatment, he presented to us, signed his informed consent, and over 3.5 hours, a lesion was produced in left-sided ventralis intermedius nucleus, a part of the tremor circuitry. And by the way, this is how the workstation looks. This is an MR thermometry, and you can see a Tmax of 52 and maximum temperature of 55 degrees during therapy. And this is Rick Trader on the day of therapy, shortly afterwards. Now, a couple words about how these structures are targeted. Ventralis intermedius nucleus is not really visible on any kind of MR technology or any kind of MR sequence. So how do we target it? Traditionally, functional neurosurgeons have used two common technologies. Number one, they can take coordinates from an atlas and superimpose it to the real images and then target the structure. Or they also have a lot of different formulas, such as this formula that is demonstrated here, where they assume that VIM is about 15 millimeters lateral in terms of commissural plane. Now, in a lot of patients, this might be adequate, but this opens a door to a lot of errors because human head is extremely variable in terms of its shape and size. And as we age at a different rate in terms of atrophy. So there's a lot of risk for off-target issues using stereotactic targeting. So right from day one, what we did is we didn't use the VIM nucleus, but we used a surrogate for VIM. We do know that dentatorubro-thalamic tract actually passes through the VIM nucleus and synapses through that. And it is very easy to use diffusion tractography to actually map this out. So we map this nucleus by mapping the dentatorubro-thalamic tract. We superimpose this on F-Gator high-resolution images. This is shown here as a target. And then we go right up to it for ablation. Now, what is the advantage of this technology? First of all, it reduces all the guesswork out of treatment. It makes the treatment shorter. It makes the lesion smaller. And it reduces the risk of off-target adverse events because motor radiations or pyramidal tract lies immediately lateral to this structure and sensory tract lies immediately posterolateral to this structure. What we have learned from essential tremor trial enrolling patients is that in some patients, if we use this formula, we would be spot on onto the DRT or VIM nucleus. In others, we could have completely missed it because here DRT is posteriorly in the posterior commissural plane. Or in some cases, we would have only partially gotten it, so leaving a door open for later recurrence of disease. I strongly believe that we need to get away from stereotactic targeting, and we need to move to direct targeting of all treatments as far as possible in functional neurosurgery. A randomized control trial for focused ultrasound thalamotomy for essential tremor recruited 76 patients, and they were assigned 1 to 3 in arms of sham or FUS thalamotomy. Patients that were randomized to sham demonstrated no changes in their tremor scores On the other hand, patients that received thalamotomy had 47% decline in tremor scores, and they were maintained over a 1-year period. There were some adverse events. They were relatively minor and transient. Most of the adverse events were related to paresthesias or some gait difficulties. When you look at secondary measures of disability score, FUS thalamotomy patients declined 62% in terms of their disability compared to sham patients that showed no changes. And this improvement was in all domains of life that make it miserable for essential tremor patients. Look at what happened to social activities, about 80% reduction in disability over a 1-year period. Because of this compelling data, FDA approved this therapy for commercial use in 2016, shortly after this paper was published in NEJM. The second disorder to benefit in a major way was Parkinson's disease. At this time, pivotal and pilot trials have both been completed, and last year, FDA also has approved pallidotomy for clinical use in commercial space. So it is available to patients commercially. In order to do pallidotomy, we target globus pallidus interna. This is a little bit of a tricky nucleus because it is surrounded by motor radiations or pyramidal tract on the medial and posterior aspect and optic tract on the inferior aspect. In order to safeguard those structures, we again do diffusion ptactography and we superimpose them on F-gator images. The target is right here next to the pyramidal tract in the ventrolateral pallidum. And you can see because of submillimeter precision, a lesion can be created without at all encroaching the internal capsule. This is the beauty of these techniques. Also during treatment, we can go in and patient is completely awake, so you can monitor them for any kind of adverse events. MR-guided focused ultrasound pallidotomy for Parkinson's disease also has shown equivalent safety data. In fact, in the pilot trial of pallidotomy, there was no adverse event that rose up to the severity of being called severe adverse event in terms of FDA verbiage. And unified dyskinesia scales decreased 59% in patients that were treated in this trial. Now, this is a very, very compelling video. Again, another advocate of this program, Kimberly Spletter. She was the first patient treated at University of Maryland or in the United States with pallidotomy for Parkinson's disease. Previously an extremely athletic individual, she was wheelchair bound with these dystonic movements. This is a home video that she sent in consideration of inclusion in this trial. And 10 weeks after her treatment, she's giving this TED talk along with Neil Cassell. Some of you who may not know him, he's a neurosurgeon at UVA or was a neurosurgeon and now heads the FUS Foundation. He's one of the biggest advocates of this technology. If you do get a chance, I would highly recommend watching this video. She's like amazing speaker. Sorry, I'm having trouble with mouse. Okay, sorry. Another big focus for me over the last few years has been application of FUS technologies for treatment of neuropathic pain. These disorders emanate from injury to any part of somatosensory system, either from nerve endings all the way up to the brain. Not only this disorder is extremely prevalent, it's incredibly devastating to patients that it affects. Causes significant loss of quality of life. There are a lot of agents that are tried, gabapentinoids, tricyclic antidepressants, opioids are also used. But when this disorder becomes chronic, almost nothing works for patients with neuropathic pain. A vast majority of chronic neuropathic pain patients are completely medication refractory. The misery of neuropathic pain is aptly captured in this self-portrait made by Frida Kahlo, a 20th century Mexican artist, who herself had spinal cord injury at a young age, and she lived lifelong with this disability. The putative target for these treatments is medial thalamic center called central lateral thalamic nucleus. This is a nucleus that has low calcium burst spikes on electrophysiologic mapping. And not only that, this plays a vital role in causing what we call thalamocortical dysrhythmia because of its widespread connections with all parts of the pain matrix, including uncus, hippocampus, prefrontal gyrus, and anterior cingulate gyrus. So when we do DBS or we do RF ablations, we make lesions in the medial thalamic center, but now we can do them non-invasively using focused ultrasound. Our first trial on neuropathic peripheral pain has been completed, and our trigeminal neuralgia trial is more than halfway done. Patients that were followed up to 12 months in patients with peripheral neuropathic trial demonstrated 39% reduction in pain. Pain-related disability. And they demonstrated 42.3% reduction in pain symptoms. Now, why this is very important is because a median duration of pain in our subgroup of patients was 13 years at presentation or being enrolled in this trial. 5 out of 10 patients completely stopped medications or markedly reduced their medications after this trial. This is Tammy Durfee. She was the first patient treated in the United States with central thalamic nucleus thalamotomy. She was a pharmacist who had been unable to work with disabling left lower extremity pain. 3 years after the treatment, she still remains free from that neuropathic pain, and incredibly grateful that she had this procedure. There's a number of other active trials that are ongoing as well, including refractory epilepsy, ADHD, potentially drug addiction with neuromodulation, and OCD. We just also heard a word that FUS Foundation will be funding our pilot trial on task-specific dystonia. So that's the next frontier for us. In terms of rate of energy deposition and duty cycle, FUS can produce a wide-ranging effects on human brain. The focused ultrasound rays can either stimulate or inhibit neuronal structures, thereby causing neuromodulation. So you can use it in chronic conditions such as pain, as well as OCD and depression. When combined with microbubbles, this technology can introduce or open blood-brain barrier. So we can use different drugs that normally don't penetrate through the blood-brain barrier in order to deliver them to the brain. And then thermal ablation is done by high-intensity continuous focus ultrasound, and we talked a little bit about this already. The reason neuromodulation and blood-brain barrier wasn't very widely adapted until very recently is because it wasn't practical. For these applications, you would have to bring these patients again and again and again, and doing head shaving and putting that frame wasn't simply practical. But now for low intensity FUS, we can do it without any head shaving. Insightec has this system where the patient can use a bite bar, and we have this system now that we have developed, which is a hinge frame. Using this type of prototype, patients can simply walk into the magnet just like they would get a normal MR, get this clamped over their head, and preliminary participant data demonstrates very, very good record of motion, it inhibits the motion in the frame. Now, a couple of words about blood-brain barrier. Our brain is a privileged organ, and it needs to be, because it needs to be protected from harmful substances, and it also needs to be protected from immunological challenges. This is typically achieved by having an intact blood-brain barrier, which consists of these following structures. Within the endothelium, there are tight junctions that affix one endothelial cell to the other. There's a basement membrane, which also has a pericytic layer, and then there are astrocytic foot processes. Together, these structures form almost an invisible cloak around the along the blood vessels of the brain, disallowing substances to penetrate freely into the brain. Now, this is fantastic in state of health and homeostasis, but it is terrible when you have a chronic disorder such as glioblastoma multiforme, because guess what? The 5-year survival rate from GBM today in the United States or elsewhere remains less than 10%, which is terrible because we have chemotherapeutic agents, we have immunotherapeutic agents that are doing wonders in the rest of the body. But these drugs cannot simply penetrate into the brain because glioma cells will penetrate far and wide into normal-looking brain at presentation. So what has enabled these technologies to open blood-brain barrier? Number one, there's marriage between high-resolution MR, focus ultrasound, and microbubbles. Number two, now we have embedded hydrophones within this transducer system. So we can actually measure the emissions coming out of the microbubbles, and we can regulate these therapies to a pinpoint, and we can choose exactly how much energy we need to deliver at what part of the brain. This is a cartoon that demonstrates how this works. The purple molecules are the drug molecules. As microbubbles are injected and then exposed to the FUS system, these bubbles will oscillate in a stable fashion. Then they impinge on the endothelial tight junctions and increase the permeability of these chemotherapeutic compounds. These compounds can then penetrate through this blood-brain barrier for a limited period, up to 24 hours or so. This can be done with real-time MR imaging, acoustic feedback, and the treatment can be extremely personalized. So that means an operator today can go and personally draw a margin of tissue that you would like the blood-brain barrier to be opened in. So in this case, for example, blood-brain barrier is opened in the normal-looking tissue or tissue that has T1 hypointensity, but not the enhancing tumor. That's where majority of recurrences occur from glioblastoma. This is the first patient in the United States that had blood-brain barrier opened. This is a patient who was enrolled in a trial called BT004 when FDA wanted proof that blood-brain barrier disruption doesn't cause any microscopic injury to the brain. So we did 4 patients at our institution. In this case, it's an infiltrative glioma. The blood-brain barrier is being opened here in the area of the white matter abnormality, and you can see a grid of 9 gadolinium enhancing spots. In this first version, we could only do a very small volume, but now if you wanted, you can do entire lobe at one time. When visualized under white light microscopy, we are looking at this area which was challenged by blood-brain barrier disruption. As you can see, it looks no different than normal brain. On the other hand, when fluorescein dyes are injected and you look at it under Zeiss microscope, you can see that fluorescein dye rapidly extravasates into this interstitium. So in future, this may actually inform or guide brain tumor resection. So surgeons could go and probably tattoo the area of the part of the brain that they want to resect, and they go in, inject the fluorescein dye, and complete the resection guided by this. And this is how incredibly conformal it can be. This is a complex surgical therapy. This is blood-brain barrier disruption in an H-shaped manner surrounding this cavity. Already in animals, all sorts of therapeutics have been delivered with safety, inclusive of nanoparticles, GDNF, even anti-amyloid antibodies have been delivered in mouse brain with safety. In addition, there's a lot of safety data that has accumulated in human brains. We can, for example, deliver temozolomide in Stoop protocol. This trial has been completed now. When patients came in with standard of care TMZ Stoop protocol, we would open the blood-brain barrier and then infuse TMZ. We are eagerly awaiting the results of this trial. They are being analyzed right now. Carboplatin has been delivered, trastuzumab for breast cancer, and now there's a new trial on pembrolizumab for metastatic lung cancer to the brain. This may also perhaps play a part in treatment of Alzheimer's disease, blood-brain barrier opening. This safety trial was actually just published, enrolled 10 patients with 3 therapies each. This trial showed that over 1 year period, the beta amyloid plaque burden in the brain treated by this technology reduced by 16%. Unfortunately, it did not show changes to cognitive abilities of people, but this is very, very early stage for this disorder. We still don't know how many therapies are essential and what the follow-up needs to be like. In closing, these are some of the clinical trials that are being conducted at University of Maryland. Some that we are really, really excited about is a potential for liquid biopsies of gliomas, because blood-brain barrier is a two-way street. In future, you could go disrupt the blood-brain barrier and in the IV measure tumor circulating microDNA, thereby not only making the diagnosis non-invasively, but also looking at molecular alterations, thereby giving personalized treatment for GBM. And again, I'm very excited about task-specific dystonia. Hope to start this within the next 6 months or so. In summary, MR-guided focused ultrasound is an early-stage technology with enormous potential. Already, there are FDA approvals for essential tremors, Parkinson's disease dyskinesia, as well as tremor-dominant variant of Parkinson's disease. And again, blood-brain barrier disruption could further unlock a potential for entirely new era of personalized neurosurgery for gliomas, as well as neurodegenerative disorders. Now, at the start of the talk, I talked about 2 blessings or gifts that I have received. And the third gift that I have received always in my career is ability to be able to, or ability to find people that really are amazing and collaborative. This is our focus ultrasound group. The ones that I would specifically mention is Dr. Mellam, who had the foresight to bring this technology to us in 2013, Rao Gulapalli, Graham Woodworth and Eisenberg. They are both, one is a past chair of neurosurgery, one is a current chair who has focus in GBM, and Howard Eisenberg has a focus in movement disorder. Again, Paul Fishman is probably one of the smartest neurologists I've ever met. Every time we are in treatment together, I always learn something new. Now, this gift for having interacted with amazing people is not restricted to University of Maryland. I've also been fortunate to have cross collaborations across institution, including many amazing people that I call friends, from Amit to Ajay, Sam, Michelle. Dr. Zay was kind enough to introduce me to Brain Attack Coalition, and right around the time in 2015-16, when all the trials were coming out, I learned so much being involved at the national level in creating Brain Attack Coalition guidelines. And again, Kevin, Charles, it just goes across disciplines. So thank you so much. I really appreciate your attention, and I'm happy to answer any questions.